Well, this year's topic, as you know, is HPV vaccine, human papillomavirus vaccine. And we are able to be here today in large part because of the ideas and support of Bill Bicknell. This lectureship is named for Bill, who's the Chair Emeritus and Professor of International Health at BU School of Public Health. The founding chair, I might say. There was no Department of International Health here at BU prior to Bill's starting one up. As an MD and an MPH, Bill has a long and distinguished career in public health, including serving as the senior physician for the Peace Corps in Ethiopia, U.S. Public Health Service. He has been a medical director of health and retirement funds for the United Mine Workers of America and commissioner of public health for the Commonwealth of Massachusetts. As I said, he's also the founding chairman of the BU School of Public Health's Department of International Health. If you know Bill, the word character applies in a whole variety of ways. He's an interesting man to work with and to have known for many years now. In establishing this lectureship, Bill thought that BUSPH should have an important role to play in shaking things up by having an annual lecture that would bring in speakers on interesting and controversial topics that would stretch our minds and make us see other approaches. And particularly wanted to focus on topics that would fulfill a main theme in BU's mission, which is issues relating to poor, vulnerable, and underserved. As you know, this event was scheduled over 2 days in order to devote one session primarily to some scientific questions, which is what we're doing this afternoon, and then the policy panel tomorrow. Bill has supported this, and it really is his brainchild, but the group that's really implemented our ideas and our lectureship this year is our Bicknell Committee, and this year it was chaired by David Ozanoff, who's the Chairman Emeritus and Professor in our Department of Environmental Health. And I remember sitting in the first meeting when we were thinking about this year's topic, and a couple of ideas came out, and then I can't remember whether it was either David or John Simon or Deb Main said HPV vaccine, and we all said, okay, that's the end of the discussion. That just had so many topics, because it's a topic rich with under-examined implications for public health, both domestically and around the world. It's a disease of poor and underserved people, the population central to our mission. It looks simple, may perhaps at first cut, and then becomes more and more complicated as you go through it. So I want to thank David and the other members of the Bicknell Committee for putting together such a fine program. And at this point, I will turn it over to David to introduce our speaker. David?
Thank you, Bob. On behalf of the Bicknell Lecture Organizing Committee, I want to add my welcome to Dean Meenans, and also remind you that there is another part to it. He's already told you that. What he didn't tell you is that breakfast will be served ahead of time, so bring colleagues, bring friends, bring your appetite, not necessarily in that order, but do come. We hope it's going to be a very engaging discussion, that the panelists are going to come at this from many different perspectives that are, to say the least, not all the same. We hope they will not only engage each other, but engage the audience in a spirited discussion of the many difficult issues that arise in this particular topic. You didn't come to hear me, so I'll get right to introducing our speaker for the first part of the Bicknell event, Dr. Susan Weller. She's an epidemiologist with unusual expertise in both quantitative and qualitative methods. And in addition to an extremely wide range of research papers, she's authored 2 texts, one on data collection and one on techniques of metric scaling, and one of her central research interests is in the measurement of beliefs and its application to minority health problems. She's a widely published researcher whose expertise in methods development made her absolutely the logical choice as commenter when the Journal of the American Medical Association published a very highly visible and widely discussed study of the prevalence of human papillomavirus infection in U.S. women. HPV is said to be the most common sexually transmitted infection in the United States, and it's also associated with at least 2 cancers. One you've all heard about, cervical cancer, and the other I just heard about from colleagues who have been doing studies here on head and neck cancer. Apparently, papillomavirus is also associated with head and neck cancer, as well as genital warts. the introduction of a vaccine that would be directed against this virus would seem to be, I think, to most of us, and when we first started talking about this topic, a public health no-brainer. Of course, we would like a vaccine that could handle a virus like this, but in fact, a closer look revealed some unexpected complexities and uncertainties, beginning with one of the very most basic uncertainties: exactly how much HPV infection is there out there? In other words, the classic epidemiologic question of disease status by person, place, and time. We invited Dr. Weller to be this year's Bicknell lecturer for the same reason that the editors of the Journal of the American Medical Association turned to her, because of her expertise in epidemiologic method, combined with a critical faculty and an astute sense of the many factors that could result in any attempt to gauge the extent of a sexually transmitted disease in a culturally heterogeneous society like ours. Because of the many uncertainties about which you will hear more tomorrow, any public health intervention, whether it's vaccine or anything else, requires knowledge of the pre-intervention baseline status. And it's this determination which is important, and just as important as it is basic, and it's as basic as it is significant. Dr. Weller's topic is a perfect example, in fact, of basic public health science coming together with cutting-edge and current public policy problems, which are the focus of tomorrow's discussion. So it's with pleasure that I now turn the lectern over to Dr. Susan Weller of the Department of Preventive Medicine and Community Health and the Seeley Center for Vaccine Development at the University of Texas Medical Branch in Galveston. Dr. Weller.
Hi, it's a pleasure to be here.
This is advanced.
Uh,
Advanced.
Do you have a pointer?
There's a pointer right at the top.
Okay, thanks. I was hoping to get a little bit cooler weather, but looks like that's not going to happen. A lot of people have turned out today, and I'm not sure about your background, and so I'm talking sort of generally. I'll tell you in a minute some of the things I'm going to review. Some will be not new if you're a medical background, and vice versa if you've got an epidemiologic background. So what's the big deal about HPV and what is it? It's a human papillomavirus, and it's considered to be a necessary but not sufficient cause of cervical cancer. What that means is that although most cervical cancers are positive for HPV, only some people, not all, infected with HPV may go on to develop cervical disease and possibly cancer. So what I'm going to talk about today are under a couple of general headings. First of all, I'm going to try to review why we think HPV is a cause of cervical cancer. I'm going to focus on cervical cancer. It's actually involved in many or several cancers now that we know of. I'm going to review some of the stages of cervical disease and the terminology for those stages, because you may hear those terms again tomorrow. I'm going to talk about the distribution of HPV in the United States and a little bit what we know in the world. I'm going to show you briefly some historical trends in cervical cancer and finally make a few summary remarks. So if you have an epidemiologic background, you know that there are a few criteria that need to be met before we conclude that an agent is actually a cause of disease. And cancer is one of a difficult kind of diseases in that we cannot randomly assign people to the agent or not, and all of our evidence is based upon observational studies. So the first thing that we look for is a strong and consistent association between the agent and the disease. And here's an example of one such study. This is a study that summarized together 11 case control studies across 9 countries comparing women with histologically confirmed squamous cell cervical cancer with women without cancer. 91% of women with cervical cancer were positive for HPV, and only 14% of those without cancer were positive. This means that the cervical cancer cases were 158 times more likely to have HPV. If you're not familiar with odds ratios, that's very, very big. The other thing we want to know is that the cause actually preceded the outcome, which we do not know in case control studies. So we want to make sure that the presence of HPV preceded the disease. And here's an example of a cohort study. This is a study where they followed a group of women that had HPV but no cervical disease to look at the development of cervical disease. They examined the cervix of 618 women at 4-month intervals for 2 years. They found that women that had a persistent infection, meaning they had HPV present at 3 observations, plus they had a high-risk type of HPV, were 14 times more likely to develop a precancerous lesion. Finally, the link needs to make sense. It needs to be biologically plausible. And in this case, what's been found is that HPV DNA integrates into human DNA, shutting off a tumor suppressor gene. There are over 100 different types of HPV viruses. They can cause cutaneous and mucosal infections. The ones we're going to focus on today are the mucosal types, and there are over 40 different types, and new ones are being discovered monthly. Of the low-risk types, you'll see we're going to talk about the vaccine a little bit today, but a lot tomorrow. The types involved in the vaccine are the 2 low-risk types, 6 and 11, and 2 high-risk types, 16 and 18. The division into low-risk and high-risk types has to do with they're classified by the degree to which they're likely to cause cancer. High-risk types are associated with cancer. The low-risk HPV types are associated with a couple different kinds of diseases. The first are anogenital warts, oftentimes reported to occur in about 1% of the population. That's probably not accurate given some of our new prevalence estimates. It's probably less, but there are a common occurrence. Low-grade genital lesions, sometimes called mild cervical dysplasia, is also caused by low-risk HPV. And a third condition, recurrent respiratory papillomatosis, rare but can be severe in young people. The high-risk HPV types are associated with high-grade dysplasias, or what are sometimes called precancerous lesions of the cervix. I'll talk later when I get to the nomenclature and describe some of the cervical intraepithelial neoplasm terminology. They are also associated with cervical cancers, of which HPV 16 is the most common kind that's been isolated. And HPV is also associated with other anogenital cancers. When we describe the distribution of a disease in a population, there are a few terms that we use in epidemiology. One is incidence. Incidence is the rate of individuals without a specific disease at the beginning of a time period who develop a first-time primary invasive cancer. National incidence data that we have for the United States are estimated from the American Cancer Society from the Surveillance, Epidemiology, and End Results, which are population-based registries. Mortality, which is another index of disease, is the actual number of deaths by disease standardized by the population. Here are some of the cancers associated with the high-risk HPV types. Cervical cancer occurs, there are about 8 cases per 100,000 population. It also occurs in, HPV is thought to be a causal mechanism in vulvar, anal, penile, and vaginal cancers, but these cancers are less frequent than cervical cancer. The oral and oropharyngeal cancers are also may be caused by HPV. The distribution, however, is different whether it's oral. There's a very low percentage are HPV, but oropharyngeal have a very high percentage of HPV. In cervical cancers, over 95 HPV has been isolated in about 95% of cancers. In anal cancers, 63 to 90% have HPV, depending on the source, the reference source. And penile cancers, 80%. The vulvar and vaginal, I just didn't have the number, didn't locate the numbers. And the oral and oropharyngeal depends on the site, whether you're talking about the mouth or oropharyngeal. HPV infections are usually asymptomatic, and they resolve by themselves. 50% of infections clear spontaneously within 6 months. 70% are gone within a year. 91% are gone within 2 years. Persistent infections, however, are more problematic. A persistent infection can be defined as an operational definition that an infection that's present with the same type of HPV at 2 or more visits, 4 to 6 months apart. Individuals or women with a persistent HPV infection are at 10 to 14 times increased risk of high-grade cervical cancer lesions. The natural history of cervical disease is that we think that the exposure to HPV occurs at about when sex is initiated, or the sexual debut. The infection usually resolves within 6 to 24 months unless there's a persistent infection. Persistent infections, with persistent infections, a woman may develop cellular abnormalities, but even the cellular abnormalities usually regress within 24 months, depending upon the HPV type and the depth and the size of the lesion. The larger the lesion, high-grade lesions are more likely to persist and develop into cancer. In the cervix epithelium, normal epithelial cells look like the first picture by normal. They're organized, they look like a brick wall, everything's orderly. But with cervical intraepithelial neoplasms, about the top third shows cellular disorganization, cell proliferation, abnormalities in the nucleus. The second level, SIN2, that disorganization has moved down now to about 2/3 depth into the epithelial layer. And SIN3, it has gone all the way down to the basement membrane but has not penetrated it. It's at the SIN3 stage that the HPV DNA integrates with the human DNA, turning off the tumor suppressor gene. A second kind of terminology has been introduced, and it's basically has 4 categories: a normal or non-HPV category, a low-grade squamous intraepithelial lesion, or SIL, which is comparable to SIN1, high-grade SILs, which is like SIN2 and SIN3, so it's a little bit of a simplification. And they introduced a 4th category, which comes back sometimes on pap smears, is the we don't know, ask us category. And here's the combination of the different terminologies across the 3 different methods. So there's a traditional pap smear, that's the farthest column. The class 1 and and the beginning of class 2 tend to be normal, but from 2 to 5 you have abnormalities present. And you can see how they link to the SIN 1, SIN 2, SIN 3, and over to low-grade SILs and high-grade SILs. This slide shows a relationship between different kinds of HPV infections and cervical pathology. So in normal cervixes, they tend to be about, so in this sample, 91% were negative for HPV. As we move across with more advanced lesions, so we get to high-grade SILs, or the precancerous lesions, you see that now 77% of these are positive for a high-risk type of HPV, and cervical cancers, 84% are positive for high-risk HPV. I'm going to turn now to some studies looking at the occurrence of HPV in the US population. A study was published earlier this year based on a nationally representative sample of women, 14 to 59-year-olds, from the NHANES data. They isolated HPV DNA. HPV cannot be cultured. It has to be, the DNA has to be isolated. And they did this with a self-administered vaginal swab, and they tested for 43 different types of HPV. What they found is that in the US population of women, 27% had an active HPV infection of some kind. 18% of women have an active low-risk infection, a low-risk HPV type infection, and 15% had a high-risk type. The NHANES data set is the National Health and Nutrition Examination Survey, and it is the data that we often use to track trends in morbidity in the US population. It's sponsored by the National Center for Health Statistics and the Centers for Disease Control. In this particular analysis, there was a representative sample of the US population, and they ended up with 1,921 usable specimens. They tested for bias in that sample and found that they did have bias. What that means is that people who were born outside of the US with other ethnicity and young, and those who have never had sex, are not as well represented in this particular data set. They tested for HPV using a self-administered vaginal swab like a tampon. This isn't the best way to do it, but it's an acceptable method in surveys. The best way is a physician's cervical sample, and studies comparing self-collected vaginal samples with cervix samples show fairly good agreement. Not perfect agreement, but fairly good agreement. And as I said, they've tested for 20 low-risk and 23 high-risk types. This is the pattern that they found with the prevalence. So the very top, well, this is the whole sample right here, the blue. And what we see is that the peak is among 20 to 24-year-olds and descending across age groups. The line just above it is the subsample of those who are sexually active. Those who are sexually active have more of it, but by the time they're about 25, the curves coincide because by then most people are sexually active. On the bottom, what we have are the prevalence patterns of the low and the high-risk types. The yellow is high risk, and we see a similar kind of pattern, actually for all of these, with the peak occurring in the 20 to 24-year age group and then descending. This has got a little bump in it. The low risk goes like this. And you can see this is at about 27, 31%. But the whole sample at that age, although the entire population, 27% are positive for an active HPV infection, in this age group, we're going up to 45, and sexually active, almost 50% are positive. This is the prevalence by each individual type of HPV. And it's interesting. I know it's a lot of numbers, but the vaccine will target low risk 6 and 11. So in this sample, about 1% of the population is positive for 6, and 0.1% is positive for 11. And when we come down over here, these are the bad ones. These are the oncogenic types. 16 occurs in about 1.5% of the population, and 18 in 0.8% of the population. And overall, we have 3.4%, or 3% of the population is positive for any one of those types. And people can have co-infections. There was another study done with a nationally representative sample, but this study focused on adolescents. It was based on the Ad Health survey and sampled young women between 18 and 25 years of age. They collected their HPV DNA in a slightly different way. They collected urine samples, and they cultured 27 different types. They found that among the adolescents, 27% were positive for some kind of HPV, 15% had a low risk type, and 20% had a high risk type. This sample is a representative sample of adolescents. It's an ongoing prospective study. In one wave, they went out and collected the urine samples and got 3,262 usable specimens. Now, the two studies differ in their findings and they differ in their methods. Although both claim to be nationally representative samples, we get slightly different estimates from the two. The N. Haynes did a very broad sample of age between 14 and 59, and unfortunately, if you look closely at their data, they have a very small sample of 20 to 29-year-olds. Whether that was by design or is a boo-boo is not clear. The other study has a very good sample size in that age range. The N. Haynes used a vaginal swab. As I said, it's got a pretty good agreement with physician-collected cervical samples, but it's thought to perhaps overestimate low-risk types of HPV because the sampling may represent more vulvar rather than cervical infection. The Ad Health urine samples probably underestimate prevalence by a factor of 1.23. And the N. Haynes, a big plus is they selected, or they did probes for many more types of HPV. Based on the methodologic differences, we would anticipate that the N. Haynes estimates should be quite a bit higher than the Ad Health estimates. This top piece of this table is based on a subsample of comparable people. So remember, the Ad Health is sexually active 18 to 25-year-olds. When N. Haynes divided their data down to look at the same subset, they got pretty similar answers for this, for low-risk HPV 6 or 11, the vaccine-targeted ones. But here we have, not only is this not higher than this, it's significantly lower than the Ad Health number. When we look at the overall, for all low-risk types and all high-risk types, NHANES did not report these by sexually active 18 to 25, and what these numbers are is the 20 to 24-year-olds. And we see that the rates here are much higher. So who's right? Well, we don't really know. What we do know is there have been a half dozen other studies of university women, and they all come up with estimates in about the 20 to 40% range overall for this age group, which is more comparable to the ad health measures than to the NHANES measures. Did we learn anything about the pattern of prevalence of this infection in the United States? I mean, what we saw from the NHANES is it looks like young women begin having sex, they get infected, it starts to go away and declines with time. And remember that these are cross-sectional data, not longitudinal. So let's see what we find about that. Is that what we find in other countries? In a study comparing the patterns across 15 samples and 13 countries, these are all population-based samples with pelvic exams. These are physician-collected or medical professionally collected samples. This is what we find in Europe, Argentina, and Asia. It's a very similar pattern. The European samples are Italy, Spain, and Netherlands. We see the same kind of thing. It's high for young people with a linear decline with age. Well, that looks kind of like what we had in the United States. But wait, look what happens abroad in other places. We have some sites. This is Thailand and Hanoi, Vietnam, where prevalence is low and it stays low. We have some other places, India, Africa, Nigeria. It starts high and it stays high. These places have a different kind of pattern. It's flat. And Chile, Colombia, and Mexico have what we call a J-shaped curve. Starts out high, goes down, and comes back up. We don't know why. And China, and I'm sorry I didn't get the picture of China, China just goes up. Now, the studies that I just mentioned, when they're isolating HPV DNA, what that means is that somebody has an active HPV infection. After you have an infection, you may have antibodies to that infection, and a blood test would detect that, and that's called seroprevalence. So another sample that was done within the NHANES was looking at the seroprevalence or the antibodies to a particular HPV type, HPV 16, because that's one of the ones that's most commonly isolated in cervical cancers. They had 7,218 specimens. They had a similar response bias problem. They reweighted to try to correct it. What they found is that the seroprevalence or antibodies to HPV 16 are twice as high in women than in men. 18% of women across the age group were positive. They had antibodies to HPV 16, and only 8% of men did. The pattern varied by age, but doesn't match the pattern that we saw for a current infection. Remember, we saw it go up and then continue down. This is the pattern for women. It peaks at 20 to 29, drops, and went back up again. It's got two peaks, and for men, we see it go up and then plateau. So who's at risk for getting HPV? What do we know about that? Well, turns out anyone who has sex or has skin-to-skin contact with another human. This is an equal opportunity virus. Everybody is eligible and usually susceptible. Variables that indicate sexual exposure, like sex, have you had any sex, your number of partners, but not only your number of partners, your partner's number of partners. And that's an important thing to remember, because unfortunately in the literature they often refer to promiscuity as in referring to the woman's number of partners. But the odds of exposure go up, not just with a woman having more partners, but with her partner having more partners. The earlier age of sexual debut may be an indicator for longer sexual exposure and other STIs, other sexually transmitted infections. The timing of exposure seems to matter. So during periods where there are changes in the cervical epithelium, it seems to be more susceptible to infection. That would be puberty, and that may be what the variable earlier age of sex is. It's that time where the cervix is more sensitive, and during pregnancy. And one of the other variables that we see sometimes predictive of an infection is parity. Smoking is also associated with HPV infection, and it's because a few studies have found that those that smoke are more likely to have a persistent infection, and immunocompromised also. In the NHANES study, they did an analysis to look to see who had a current infection in the US population, and found that variables indicative of exposure to a sexually transmitted infection overshadowed variables like race, ethnicity, and socioeconomic differences like educational level and income. Those variables were younger women that were in the 20 to 24-year-old age group were twice as likely to have HPV than other women. Women with a greater number of lifetime partners, if you had 3 or more partners, you're 3 times as likely to have an infection. Those that had a greater number of partners in the last year were 4 times, if you had 2 or more partners in the last year, you're 4 times more likely to have an infection. And being unmarried or separated were also 2 to 3 times more likely to be infected. So how can we prevent HPV? So one solution is to never have sex. Well, let me tell you, that will not eliminate risk. It only reduces risk. It reduces risk by 50 to 75%, but it does not eliminate it. And as you go about shaking hands today, let me tell you that 2/3 of men with genital warts have had HPV isolated from their fingers. And 1/3 of women with genital warts, it's been isolated from their fingers. What about condoms? Do condoms work? There was a meta-analysis of 20 studies. The results were mixed, suggesting a possible protective effect for warts, CIN 2-3, and invasive cervical cancer. But in that meta-analysis, there was actually only one cohort study, which is the proper type of study to study this. And in that cohort study, they compared always and never condom users, found a relative risk of 0.80, which means there was only a 20% reduction in the likelihood of a high-grade precancerous lesion or carcinoma in situ. There's another study that showed a newer study, actually, a single study that showed a 70% reduction in risk. So that one is more convincing, I suppose, but it's not clear. One interesting finding with that is that one of the studies found that women that had high-grade dysplasias were significantly less likely to have a recurrence if they used condoms, which suggests that men may actually may have some role in infection. The historical progress we've made in cancer reduction is quite clear. There's been a 75% reduction in the incidence of invasive cervical cancer since the 1950s. And why is the 1950s important? That's when the Pap smear became available. There's been a 70% reduction in mortality due to invasive cervical cancer since that time. This is a plot that you can see women over 50, all women, women under 50. This pattern is evident in all ethnic racial groups. You can see also the decline in mortality. These are the older women, the women more likely to get it. Oops. The success in reducing invasive cervical cancer has probably been due to screening and early detection of disease, earlier treatment, and some other factors. It turns out that there was a decrease in invasive cervical cancer prior to the Pap smear. This is a federal slide showing the high rate of Pap smears by racial ethnic groups, and it's running at about 70 to 85%. This shows the decline in mortality. The one called uterus is the one that has cervical cancer. Mid-1950s are around in here. You can see the decline since the Pap smear, but quite clearly there was a decline prior to the Pap smear, indicating that there are other factors involved in this. I'm going to make a few comments about the HPV vaccine. I'm not a vaccine expert, and the experts will be here tomorrow. The new vaccine is a quadrivalent vaccine. It has 4 types of HPV in it, 2 low risk, 6 and 11, and 2 high risk types, 16 and 18. 6 and 11 are the ones commonly associated with anogenital warts, and 16 and 18 are isolated in most cancers, cervical cancers. It's important to remember that the vaccine will not eliminate cervical disease. There are 40 different HPV types, about half of which are oncogenic. The vaccine is going to attempt to knock out the 2 most common, although what we saw in the NHANES is that 16 and 18 in the United States didn't look like they were the most common in the population. The vaccine will not cure a current HPV infection. It is currently recommended for 11 to 12-year-olds with a catch-up cohort, meaning, yeah, you should probably get it also if you're 13 to 26. It's going to be a while before we see an effect in the US population. So I'm going to make a few comments about the vaccine, and let the people tomorrow discuss it. Probably one of the best sources right now reviewing the epidemiology, the biology, and the vaccine is the article that came out earlier this year in the MMWR by Markowitz. This is the report from the panel on vaccines. It's a CDC report, and one of the sentences which I thought was very good, although it was buried in the middle of the report, is that many aspects of the natural history of HPV are poorly understood, including the role and duration of naturally acquired immunity after HPV infection. This is a disease that comes and goes, and that you may have antibodies to and you may not. They think that over about 60% of people with active HPV infection do not have antibodies. And there are few data exist on the cumulative risk for HPV infection. When I started looking at these studies on HPV, I was actually a little appalled at the lack of longitudinal data following people without HPV forward in time to look at cervical disease stage. And then when I started thinking about it, I realized why we can no longer do some of those studies. Some of the studies that are in the literature now are coming from places like Brazil and start out with a sentence saying, this is a prospective study looking for the occurrence of SIN1, some of the initial stages, SIN2 and SIN3, because in Brazil, in this setting, SIN1 is not usually treated. So we can no longer do a natural history study of a prospective nature because it becomes more like a Tuskegee study. We can, however, we can follow forward to cervical disease, but we have to treat the disease in this country. There are many unknowns in the pattern of HPV. We're lacking in longitudinal data, and we need to be cautious when we're inferring longitudinal patterns from cross-sectional data. The question is the mandated vaccine premature? Is it premature to mandate it? What we know from some of the phase 2 clinical trials about efficacy was that, so they've studied in some trials 16 to 23-year-olds, and they followed them for a median of 2 years. Efficacy for the more serious high-grade SILs or SIN 2 and 3, but these are not any SIN 2 and 3. These are 6, 11, 16, 18 outcomes that they were looking for. Efficacy is estimated for all people originally enrolled in the trial to be between 23 and 52% effective. When they take a subset of people that followed protocol and eliminated people that, say, only had 2 of the shots instead of 3, efficacy is 93 to 100%. When they look at the more general form of any kind of SIN present, a 6, 11, 16, 18 SIN, overall efficacy is 35 to 56, but in the subset it's 87 to 99. Effectiveness for warts, 58 to 77%, efficacy 94 to 100%. One of the problems with a short period of follow-up, remember this is a community-based trial, and most of these people will not have been exposed yet to HPV. They have done a sub-study, a 3-year follow-up for antibodies, finding antibodies seem to still be there at 3 years, a little bit lower for HPV 18. And there's now a 3rd phase trial, and I'll let the experts talk about some of that. So what do we know about this? So it's recommended for 11 to 12-year-olds. And let's take our 12-year-old. She's in the 8th grade. She had her braces off this week. Do we vaccinate her? Well, we have 2 years of experience from the phase 2 trials. But we don't even know yet how long that vaccine is going to last and what its effectiveness is going to be over the long run. So the 8th grader, in 5 years, is going to be a senior in high school, and probably like most seniors in high school, she'll probably be starting to have sex. This is when we want them covered. 10 years out, we're right in the middle of the high-risk period, and we want them covered. Will they be covered? We don't know yet. Will we need a booster shot? We don't know. Two more final thoughts are, what about the cost effectiveness of the vaccine? Well, shouldn't the cost effectiveness studies be redone now that we have prevalence estimates on the US population, and those prevalence estimates are lower than we thought they were going to be? The lower the prevalence, the less likely that someone will be exposed to it. And what about the cost? Gardasil is $100 for an injection. It takes 3 injections, but it turns out somebody has to give the injection, and they have to have somewhere to give it. In our clinics, it's $600. And shouldn't the cost effectiveness studies be done by somebody unaffiliated with Merck? I say that with tongue in cheek, but the most recent cost effectiveness study was done by Merck, and they found that it would in fact be cost effective to vaccinate every boy and girl in the United States at $600 a person. And a final comment is about access to medical care. One of the things that we see in the United States and in industrialized countries is that invasive cervical cancer has declined steadily, probably a lot to do with screening and access to care. The women that are still getting, there's a higher proportion of women with invasive cervical cancer who have no access to care. They tend to not have health insurance. They haven't had a pap smear in 3 years, and they're more likely to be black or another minority, an African American. Interestingly enough, Medicaid is paying for the vaccine. Now that if we improved access to care, we may make a difference by who we reach. That may make a big difference in the long run. And so I'm just going to close there and let you, if there are any questions, blank. And tomorrow, the experts will be here to talk about vaccines. Yes. I think, I'm going to have to interrupt you. I'm sorry. I think they want you to come to a mic, if you don't mind.
Can you hear me?
Yeah.
Okay, great. When you were talking about the hand carriage of HPV, I was just wondering...
The what? I'm sorry.
The hand carriage of HPV,
yeah.
You're talking about that. I just wanted some clarification, because my understanding is that the warts that you get on your hand, for example, is HPV unto itself. But what you said up there was that those with genital warts identified that they had HPV on their hands, but was that necessarily...
Yes, it was the genital HPV.
Okay.
Yes. And in the national data, about 5% of people who have never had sex are positive for HPV also. Yeah.
Thank you for a very informed presentation, so that even those of us in the audience that don't know very much about the clinical aspects could really grasp it and understand it. I wanted to ask, can you answer this question, or will we hear more about it tomorrow? That it seems that part of what we might consider is if there are any untoward effects of the vaccine. We know that there are 40-some different kinds of HPV vaccine. We know that it has that what is being given in Gardasil attacks 4, too low and too high. That already gives us something to think about. But are there any known side effects or long-term implications of this vaccine for girls that eventually will be childbearing?
Not yet. I mean, no. In the MMWR report that I mentioned, they lay out everything, and they go into detail. So they looked at problems at the time of vaccine, like pain, itching, fever. They looked at problems over a shorter period of time, and it doesn't look like there are problems for the time period that they've looked at.
And what is the time period they've looked at?
Somebody here is an expert on that because I don't remember. I know they did, well, they're monitoring these people right now, so it's probably only over 2 to 5 years is as far as they are in the trials.
So not very long.
Right. I mean,
Yeah.
it's not recommended for pregnant women, but I think if you're lactating, they think it's okay.
I was trying to get a sense for if we're going to inoculate all these girls, whether or not we know that there are going to be any long-term sequelae for them when they are 10 years old or 20 years older, should they choose to have children or should they choose to live?
It's too soon to tell. But I mean, one of the arguments that's been raised is, gosh, what happens if you knock out 16 and 18 and the other ones move into that ecological niche? And we don't know. But it's an informed decision to go after 16 and 18 because because it's more commonly identified in the cancers.
Thank you.
Could I ask you to review the efficacy data that you presented? I couldn't quite keep up with you when you made the distinction between the two groups. That's part one of the question. And then part two of the question, are these efficacies pretty much in keeping with vaccine experience, or are these somewhat atypical? Are we putting too much faith in the rather high efficacy rates that we saw?
I can answer half your question. The other question I'm going to have to leave for the experts. It is common in an experimental study to do an analysis on what's called intention to treat. So that means if they got assigned to the vaccine and they got assigned to the placebo, we're going to analyze it that way, even if they disappeared, they didn't complete the protocol, or something else happened. And that is the very conservative lower estimate. The second analysis, which has received much more attention, is they went in and said, okay, so you only got one of the 3 shots, you only got 2 of them, or you didn't get them on time, we're going to kick you out. And those are the higher estimates. So one is more like efficacy, those are the high ones, and effectiveness is more like what happens in the community. Now, whether it's comparable to other vaccines, somebody else has to answer, and maybe they'll do that tomorrow. Okay. No more questions. Thank you very much.